All right, perfect. Ben, Dr. Norris, what do I refer you as? What do you
Ben's
prefer?
good. Thanks. Yep.
Ben's
All good.
Ben's fine. Perfect. No, doctor, plastic surgeon. I always get confused. Plastic surgeon, cosmetic surgeon. You're a plastic surgeon, is that right?
Yeah. So I'm a plastic and reconstructive surgeon. So that's the actual formal title. The difference, I'm also a cosmetic surgeon. So I'm a plastic surgeon who does cosmetic surgery. So just to bring everyone up to date, so until very recently, anyone who had a medical degree in this country could call themselves also a cosmetic surgeon. So they could do cosmetic surgery without necessarily any other qualification. So that's changed recently. So that was brought into law. So now you cannot call yourself a cosmetic surgeon unless you actually have a surgical degree of some kind. What that means then, of course, is an orthopedic surgeon trained in orthopedics could also call themselves a cosmetic surgeon. So to call yourself a plastic surgeon, that's now a protected title in this country. Also, recently, you have to have done the College of Surgeons, the Royal Australasian College of Surgeons in this country, plastic and reconstructive training program, or an equivalent from an overseas institution.
Okay, was that the Four Corners? I remember watching the Four Corners report that shed a whole bunch of light on the crazy cosmetic surgery industry.
Yeah.
Is that what it was? That sort of the
Well,
domino?
the Four Corners thing was the culmination of a couple of years of ongoing issues, and some of which had been sort of pushed forward by our own societies. So, Australasian Society of Plastic Surgeons, Society of Aesthetic Plastic Surgeons, the Royal Australasian College of Surgeons. So, what that program demonstrated was that it was an unregulated industry. So, again, it wasn't just the likes of me doing breast enlargements, breast reductions, tummy tucks. There were a whole bunch of people calling themselves surgeons and really effectively and legally doing that type of surgery. But because they weren't necessarily trained in the surgery nor having any oversight, things are fine until there's significant complication. And that's really what the program was about. Um, don't get things wrong though. All surgeons of any variety get complications. It's how you manage the complication and how you manage the patient afterwards that really determines the outcome.
Right. So previously, if I'm correct, like if you were a doctor of any kind, you could just jump into cosmetic surgery, no surgical practice whatsoever, and you just go
Yes.
in, you just
So
start.
no,
Yeah.
so there is a competing organisation, if you want to call it that, which is a cosmetic college, and they were training their own people. But for instance, you could be a psychiatrist, go and do their 18-month course, and then call yourself a cosmetic surgeon, and that so that has now been regulated out. Um, of course, one of the issues is, are we seen to be protecting our own turf as plastic surgeons? Say, well, we only want people with my qualification to be doing cosmetic surgery. But in fact, that's a little unfair. There are people that can be trained certainly to do what I do through other avenues, and that is also being addressed by our societies, including the College of Surgeons, with basically you being grandfather claused into the title cosmetic surgeon. So, it doesn't have to be us and them, which is often how it's set up in the media, and certainly and it can come across that way the moment we say, listen, we have concerns. It's designed ultimately, as it should be, to protect the patient. Only people who are qualified to do that surgery and manage the patient pre and post operatively should be doing that type of surgery. It doesn't matter whether you're a plastic surgeon, a cosmetic surgeon, or some other surgeon. If you're qualified to do it, you're entitled to do it. You just got to do it well.
Right. So then, obviously, cosmetic college that's not acceptable anymore. And then the Royal is that the certificate behind you there? That Royal Australia
Yeah,
College of.
so there's a number of certificates there. People like me, to get to where I could put up my shingle for the first time as a plastic and reconstructive surgeon who does cosmetic surgery is 15 years from the moment have decided you might join med school, and now probably longer. My generation a little bit different than the current generation, so it's a
So
long
that
way. But those things reflect not only having been through the College of Surgeons training program, which is the only recognised program for training plastic surgeons in this country, but also spending time in an overseas institution, doing the Society of Aesthetic Plastic Surgeons courses and those sorts of things. So that, those are just certificates. But bottom line is that's what patients should be looking for.
Right. Okay. So if I'm let's say I'm in high school and I've just graduated, obviously I want to, study medicine. That I assume that would be the first step, right?
Absolutely.
Then what are the steps after that? Because you mentioned 15 years. I don't know how long does a medicine? I mean, does it take?
Yeah, so the first thing is you're going to have to do a basic medical degree, whether it be in this country or overseas. But if you want to practice in this country, it has to be recognised in this country, and so that's 5-6 years. Then you'll be expected to start in a hospital environment, a public hospital environment, and you're taken on as a resident or house surgeon in this country, a resident, and eventually you'll make your way onto specialty program training. But in my day, we all became general surgeons first. So I trained as a general surgeon first. That's what was expected of my generation. And then you transferred over to the plastic surgical training scheme. So you basically did 4 years of general surgery and then 5 years of plastic surgery. And then I went overseas for a couple of years. You were expected to go and do some overseas training. That things have changed. The current generation do not expect to go and do a general surgical course that they're never ever going to use in reality in their day-to-day practice. So those days are over. So now you're competing as a hospital resident to get onto a specialty program, which in this country is the Plastic and Reconstructive Training Program. And once upon a time, you could take as many attempts as you wanted to get on. That's changed. It's designed to stop people from sitting around, not ever being told they're never going to get on, or hanging around for an unnecessary length of time. So now you're allowed 2 attempts in Australia to get onto the training program. And should you not be selected onto the training program after 2 attempts, you're never allowed to apply again. That's the current rule. These things are always being updated. So you've got to be fairly certain that once you've made the decision to try for the plastic and reconstructive surgery training program, that you have got all your ducks aligned. And there are certain things that are expected of you to have your ducks aligned.
So what is expected of you to, like, what if I apply and I'm just like, oh, I'm not good enough? How do I know if I'm good enough or not good enough?
So it really comes down to CV points. So it would be unusual now to not have gone and done a master's of some kind before applying for the plastic trade. So in my day, and I'm not, I'm a different generation than your listeners, but I was the first in Sydney to go and do a Masters of Medicine in Clinical Epidemiology. And the reason why I did that was one of my mentors at Royal Prince Alfred Hospital had done that in Ireland, and they were starting the program at Sydney Uni, and they asked if I wanted to be in the first graduating class, so I did. But, that worked in my favour, but it was considered unusual at that time, and I started plastics training in the year 2000, and it's now, 2025. So now it would be almost impossible for you to get on without having done either a Masters of Surgery or some sort of medical masters, basically.
Yeah, okay. Because, obviously, to do a master's degree, you've got to have, I don't mean to be rude, but you've got to have a certain level of intelligence to get and study a master's and get there. When I think, and maybe I'm wrong when I think of this, when I think of plastic surgery, I'm thinking art. I'm not really thinking science, right? Am I right there? Is it a combination of both, or?
Listen, no. So a lot of the surgical specialties are basically very anatomy driven. So, and it's no criticism of orthopedic surgeons, but I often use it as an example. It's very anatomy driven. It's bones, joints, machinery. Plastics, it crosses all of the tissue parts of you, and so it's actually quite a technical exercise. You've got to know the anatomy, obviously, so you have to be an anatomist, which you're taught in med school, so it's not something extra you have to go and do, but you have to be quite technically driven. Art is a bit of a I won't say the word out, but it's a bit bullshitty, because
you can say the word out loud.
so it can be a bit of a wank. Everyone go, oh, you're an artist, but the reality is a better term might be slightly creative, and you also have to be able to think on your feet. So you've got to be able to pivot quickly. So you can be presented with things during a plastic surgical procedure or a cosmetic surgical procedure that requires you to gently change tack very quickly on table. And I think that's where the creativity or artistry comes into it. But in terms of, can I draw a 3D figure as beautiful as Picasso? Well, no, the answer is definitely not. You don't need those types of skills.
Yeah, right. So is it and everyone says this with all types of roles, is that no one job is the same, no one case is the same, right?
Yeah.
And I guess that's what you're alluding to, is that if you're going to be in a surgery and something happens, you need to think on your feet and be creative and figure out how do we solve this problem. But and again, maybe my assumption is wrong here, but if is one boob job like another boob job, is it all the same, or is it much more different than a
Listen,
simpleton like me would believe?
That's a fair enough question, but the bottom line is there's some common features of most operations that I would do that are common to most patients. But the reality is every person is different. So every patient is different, every breast or tummy or face is different, and therefore every operation is different. What good plastic surgery is about is taking some sort of baseline procedure and then basically modifying it to the individual. And that's where the technique comes into it. Anyone can be taught to make a cut. It's how you modify what you do to that particular individual. Does that make sense? Whereas, for instance, and again, it's not a criticism of, say, an eye surgeon putting a lens in, there is only one way you can put a lens into someone's eye. Does that make sense? So really what it is about individualizing the operation to the individual patient. And that's, I think, the beauty of plastic surgery, reconstructive surgery, and cosmetic surgery.
Yeah, right. Okay. So, speaking of boob jobs, then, if I may, is that it? Sounds like
You keep coming back to the boob jobs. Yeah.
This is what it's all about.
Oh yeah.
Is that the most type? I mean, I assume that's the most common surgery, right?
No,
Or
it's not.
it's not. What would be,
It's
if you were to
absolutely
draw
not.
like a pie chart? What would be the
Okay, so
cuts in that?
if you had asked me that question 10 years ago, I would have said very definitely that the most common cosmetic procedure in this country would likely be a breast augmentation procedure or boob job, if you want to call it that. But in fact, overall, the most common cosmetic procedure done worldwide, let alone in this country, is actually liposuction. And that's for a particular reason. Liposuction can be done in isolation. So you can say, I want my thighs liposucted, or it is just as commonly done as part of another procedure. So, for instance, if you have a tummy tuck, that operation has a component of liposuction or liposculpture built into it.
Right.
But
Okay. So
liposuction is very definitely the world's most commonly done aesthetic procedure.
right. So then lipo number one, breast augmentation number two,
So
and then
breast surgery number two, so that encompasses breast augmentation, breast lift, breast reduction. That would be number two in this country. Then it's followed very closely by rhinoplasty across both male and female. So those are the
that's
three.
nose, or is it all?
Yes, yeah, rhinoplasty is nose job. Yeah.
Right. Okay. So then, if I were to go to a plastic surgeon, are there plastic surgeons who are specialist in all different types? Because I did a bit of Googling before this, and I
Yep.
noticed every single plastic surgeon has every single surgery. I assume for like Google SEO purposes, right? But is
Yeah.
that true, or is that just for Google?
The reality is that one of the things that attracts, I think, doctors to plastic surgery is the ability to actually have it quite a general practice. And though the reality is that you tend to fall into certain aspects of practice. So, for instance, I would not class myself personally as the number one person seen for breast augmentation in the eastern suburbs, but I would be number 3 or 4. But in the same breath, I'm number one, and I know this for a fact based on audit, that I'm the number one person that people come to see for male chest surgery, for instance. And so sometimes you don't have quite control over how your practice develops, although you can certainly advertise for everything. The reality is, as surgeons are there's a fear of missing out. They tend to want to do everything, and we are certainly trained for the most part to do everything. But I have a little golden rule. So I don't do rhinoplasties anymore because as my practice built and I became very busy in other parts of it, I found I was doing about 10 to 15 rhinoplasties a year. So I don't think that's good enough to class yourself as a healthy rhinoplasty surgery. So I would send those patients off to a colleague or someone I trusted to treat that patient well. And that's something I choose to do. So that's a part of my practice that I choose not to do simply because I'm busy in other aspects of it, and it doesn't particularly interest me enough to chase that work down. Does that make sense?
It does. It does. So if you're just starting out, like whatever you sort of get experience slowly doing, that will be obviously what you gravitate towards, that type of surgery. Or...
Yeah, I think you need to be very clear on what starting out means. So by the time you finish the plastics training program, you'll also have done a significant amount of cosmetic surgery. That's actually built into the curriculum for the training program. That wasn't the case 20 years ago. In fact, 20 years ago, the only way you could get cosmetic experience was by going overseas. It was actually a little frowned upon to want to do cosmetic or aesthetic surgery as a plastic surgeon 20, 25 years ago. That's not the case now. It's an expected part of the job. And so you can be very well trained in Australia in aesthetic surgery as part of the plastics training program. So the chances are that by the time you leave the program, complete the 5 or 6 years, you will have experienced and participated in and perhaps actually done as the primary surgeon most of the common aesthetic procedures. In my day, it was expected that you would then spend a year or two overseas in an internationally renowned unit and gain further experience in a sort of arena of your choice. So for instance, I went, I was actually invited to go to Cambridge University. I worked at Addenbrooke's Trust. I worked there for 2 years as primarily a plastic and aesthetic surgeon. And then I returned home to Australia and went straight into private and public practice. But, it's different now. I think now you can be fairly sure that you would leave the program with a good background in cosmetic or aesthetic surgery.
So you mentioned while you're doing the program, you could potentially be the lead surgeon, right?
Yes.
So if I was a patient, the way that I would think is I would want to search around and look for the most experienced person out there, right? I wouldn't want to be someone's, guinea pig, right?
Okay, that's a fair enough comment, but you've got to remember there are both public and private systems, and most plastic surgeons start off at least in both systems. So when you as a patient turn up to a public system, public hospital requiring plastic or reconstructive surgery, the chances are that you are going to be operated on under supervision by the training registrar. And you might think that you have a choice. The reality is you don't in the public system. That's what the private system is for. In the private system, many plastic surgeons, myself included, will have a training registrar come and stay with them for a year. So I've had numerous plastic surgeons that junior to me who have been my private assistant, and basically they're helping me to do the patient, not as the primary surgeon. I'm the paid primary surgeon, but they're gaining that experience. It's actually a very good way to gain experience once you're actually qualified even. But in the public system is there to train future doctors in some respects, but it's not unsupervised. For the most part, complex procedures are being supervised by the consultant surgeon. Emergencies, which are not things like cosmetic surgery, obviously, often the on-call registrar is doing the operation unsupervised if they're adequately trained and at the right level.
Right. So in a public setting, I can imagine, because you mentioned liposuction is quite often not the primary part of the surgery. It's sort of like a supplementary part to the surgery. So I can imagine how there'd be some sort of necessary surgery that needs to keep someone living, or that there's some sort of surgery they need to get done, and there needs to be liposuction attached to that. But like something like rhinoplasty or breast augmentation, like how does that fit in? Because public system, I assume that would all go
Okay,
through
so
private,
you
right?
cannot have something that's purely cosmetic done in the public system. And some years ago, it's more than so pre-COVID. In fact, you could still have things like male chest reduction done in the public if you were willing to wait on a waiting list. You could have tummy tucks done after massive weight loss. So there were some very strict criteria. Those days are over. The system is so overwhelmed. The public system is so overwhelmed that really, cancers come first and everything else is basically secondary. So you're not going to get a cosmetic procedure done in a public hospital in Australia anytime soon. So you have to go into the private system.
Okay. Then as surgeries, I guess there's public, then there's private, and then there'd be some approved and non-approved surgeries. Like what I assume when we get into this territory of plastic surgery, there's guys and girls who wants to do some crazy stuff to their body that is just not. I don't know. Let's say I wanted to make my penis longer or something like that, right? Like I don't know if that's allowed. Maybe, but
It's
is it?
allowed, but most plastic surgeons don't do it. Actually, it's actually penile lengthening, penile girth increasing is often most commonly done by urologists, as it happens. It's actually that particular operation, and more correctly, the patients that desire it. It can be a minefield, and so most reputable surgeons stay away from minefields, to be honest.
No, I can imagine. So that's an example. But are there other things where you just say no, we don't do that people are coming in and asking for, or
Well,
is
I
it
had
is
a
it the standard set of things?
Okay, so so it's like we work within or under a very much a medico-legal umbrella in this country. And to put things in perspective, we have the highest rate of litigation outside of California. So not outside the United States, outside of the state of California. It goes California, New South Wales, rest of the United States, then parts of Australia. And so we work. So there are things that we have to do based, under that umbrella. But I had a woman come in to see me a few days ago who's asked me to remove bottom ribs because she wants to narrow her waist. Now, that there's a myth that there are people out there, Cher is a good example of it, who have had ribs removed. Well, that's a load of rubbish because there is no reputable surgeon that would actually do that. It's a very unsafe thing to do. But we get asked these things. And if you offered that and did it, it would be medico-legally indefensible in this country.
So what I mean, like, what if someone had something, maybe a rib taken out would be is a bit extreme, but like I'm assuming you said there's a high litigation rate, so there's a lot of unhappy customers or unhappy patients, I should not customers, right? Like what is there? What do they do? Is there an ombudsman that they go to? Is that how it's set up, or?
Yeah, so there's a couple of pathways to making a complaint about the way you've been treated by any practitioner in this country. So first of all, there's the Healthcare Complaints Commission, and then there's the Medical Board of Australia. So those are the two primary routes. Any surgeon that's never had a complaint made against them in one form or another, even a formalized complaint, simply is not doing enough work. That's the first thing. It's how that complaint is handled. But there are pathways that are independently managed by those organisations to make sure, first of all, that the patient's complaint is heard and that a fair outcome comes as a result of the investigation into that complaint. And it's good that there be a complaint. It's not a complaint hotline, but there'd be pathways to complain. We do know that the complaint rate has taken a massive rise up. So, and there's a couple of reasons for that. People's expectations of what surgery can do for them can be off sometimes. That's been due not entirely. It has not entirely been the fault of the patient. The system and the industry, in particular the cosmetic surgery industry, has really pushed patients into, okay, well, this might be my only option is to consider having a surgical procedure. But that comes down to advertising. And now these are new changes. I would argue that we are the most heavily regulated industry in this country. And in fact, country for country, we are the most heavily regulated cosmetic industry in the world. So the way we advertise, what we can and cannot put on social media, before and afters, Facebook, any form of advertising, even what I show to patients on my own laptop in this room, the way even any pictures I put around the practice, is heavily regulated.
So,
And
so
it's
what are
designed.
examples? Sorry, what are some examples that you're not allowed to do now?
Well, you can't induce a patient. You can't say, listen, if you have this procedure, I'm going to do free set of eyelids. You can't discount, say that if you sign up tomorrow, I'm going to give you a discounted rate. You can't show patients unrealistic images. So you can't show a before image of a 40-year-old and then show a 20-year-old influencer doing a pose in her bikini. Once upon a time, not that long ago, many of my patients would, without me asking, would send photos of them in, swimsuits on holiday, posing, which is just a way of demonstrating perhaps that they were pleased with who they had become. But now that's considered inducement and advertising. So we cannot put that sort of imagery anywhere on anything with our name attached, basically.
Right. So, I mean, then how, from a business perspective, how
Mm.
do you get leads? And leads, it sounds sort of crude when I say leads, right? But any business needs leads in the door so that you can convert them and make sales. And even though we're talking about like, the medical industry here, and we should
Yep.
say patients, how do you get people through the door that you can convert through to surgeries? Because that is
Okay.
ultimately how you're making money, right?
Yes, okay. So it's a really good question, because anyone that says that we're not running a business is bullshitting. So the bottom line is we're running a business like anyone else. It just happens to be a different type of business. It's a very regulated business now, and so leads are generated in a number of different ways. So for instance, I have a full-time, you would call it a PR company. So I pay them a monthly retainer. They manage all my social media, all my reputational management. They do all advertising for us. They upgrade our websites. If we send them photos to post, they make sure that they meet all the regulations. They're also doing Google advertising for us. So that's one component of how you create leads. Having said that, the cheapest form of advertising is another patient. So now, currently, at my stage in my career, and I would be classed as an older surgeon, I guess, is 35% of my patients are people who come to me through previous patients or are previous patients themselves. So the one and done thing is not true in this industry. So most patients will have, in a practice like mine, an average of 2.2 procedures. So in other words, they have more than one thing done over a number of years. Not necessarily all in one go, obviously, but I'm now seeing people who I did their breasts, say 15 years ago, who are now coming to me to have their facelift done. So that costs nothing, and that doesn't require any lead generation. That comes down to reputation, presumably treating the patient well in the first instance at their first operation. But anyone who says that they don't need to advertise in this industry as a plastic surgeon, reconstructive surgeon, or as a purely aesthetic surgeon is not telling the truth. We need turnover like anyone else.
So it sounds like it sort of snowballs, and referrals and repeat customers. I shouldn't say customers. Repeat patients are
Clients
the
is fine.
clients. But so if you've got people repeating right now, I mean, maybe one surgery is okay, maybe two surgeries is okay. At what number? Because when do you enter the territory of like this person has a problem? This person shouldn't be continuing to do this to themselves. Like,
Yeah.
how do you? Like, I know that's a minefield of a topic, but how do you handle
Well,
that?
it's actually legislated in as it happens. It's also under the new rules. So, for instance, reputable surgeons since the beginning of time have been asking questions in such a way to weed out people that essentially you don't want to operate on. You don't want to operate on them because they're either unrealistic about what they expect surgery to do for them, or they're complete whack jobs. And of course, you're not using that terminology in front of a patient. Now, it is a legal requirement that if you are contemplating any form of cosmetic or aesthetic change, including injectables, you have to answer a body dysmorphic disorder questionnaire of some variety, and it's designed to weed out, or to select out, or to at least identify the 10% of patients that are supposed to pass through my practice every year who have body dysmorphic disorder. In other words, they have an unrealistic focus on a body part where surgery is likely to harm them further. That's it in a nutshell. Does that make sense? Um, so, but I have plenty of patients that I've known for the 25 years so far of my career who've had multiple surgeries without issue and have been completely realistic throughout. They're just aging. There's cyclical surgery. So, for instance, someone that has a breast augmentation at 20, we know that they're highly unlikely to make it through the rest of their lifetime with that single set of implants. So we tell them, or should be telling them, that the chances are they're going to have another implant-related operation at some point down the rest of their life. But that's built into the consent process, or should be built into the consent process at the time of the original operation.
Right. So those examples seem to be in older patients. And what if we switch it and we go down to the other and young people, right?
Yeah.
Who are just, I don't know. I assume there's an age limit, maybe 18, maybe there isn't an age. Actually, I heard a friend of a friend told me once, and this is just a friend of a friend, so it could be a complete bollock story. They said that a 14-year-old got a nose job, right? Is that allowed? If you get your
Yes.
parents sign off? Yeah.
It is allowed, but it's conditional. So legally, you're an adult and allowed to make adult decisions without a guardian or a parent present at 18. You can have a consultation at 18 with no one else present. That is purely legal, and you can progress to surgery once the requisite wait time has been gone. I see plenty of 14-year-olds that come to see me, particularly about male chest reduction surgery, where they're passing through puberty. And in fact, what you're doing in most cases is you're not treating the child, because they are a child at that point. You're treating the parent or parents that are or guardian that's with them. And often, so what you are, I think, obliged to do is treat that child with due respect. If they've made the effort to come and have the conversation, you do them the courtesy of giving them the information. But there are quite strict laws. So if you're having an aesthetic procedure of any kind, so in other words, a body changing procedure or body image altering procedure, you must, as a child, sit out 3 months before you're then allowed to proceed to that surgery. If you're under
Okay.
the age of 14 years and 7 months, I think it is, it might be 9 months, I can't remember, you must have a parent co-sign the consent form. But after that point, though a parent has to be involved, you're allowed to sign the consent form yourself. So the reality is in practice, how does it work? So a lot of patients will contact me on what's called HubSpot, which is our initial inquiry platform. It's an American device. And you can often tell from the line of questioning and the tone roughly whether it's a child or an adult. And if I've got suspicions it's a child, I'll write back and say, how old are you? And most people, when you say out loud something or challenge it, will tell you the truth. The moment they tell you they're under 18, I'm obliged to say I can no longer engage with you on this platform without a parent or a guardian being present. I'm happy to have the discussion with one or the other present. I would suggest you come in to see me with a parent or a guardian, and then we will and can answer all of your questions and concerns. So there are patients that come and see me at 17 years and 6 months. They have to legally sit out the 3 months before they proceed to surgery. What they do is they wait for the 18th month, 18 years to tick over, and then do whatever they want. And there's no law that prevents them from doing that. So the next step in that is say someone's 14, is it appropriate to operate on them? So a good example is a 14-year-old girl, young woman, if you want, but a child comes in with an E-cup breast. It happens. That child is going to probably desocialize, will probably be bullied by her colleagues in the playground, may choose to not go to school. There can be mental health issues, and that is taken into consideration. So I've certainly done children for breast reductions. I've done young men for male chest reduction, primarily because of desocialization from, they're just not going to school, they're not taking part in normal activity because they're so distressed by their parents. But if a 14-year-old came into me and mum said, I don't like the child's nose, I want you to do something about it, then of course you would be most unwise to consent to that. And in
So
fact,
then,
it would be hard to defend it in a court of law, actually.
I can imagine. But then, okay, so you said 18, they can do whatever they want, and fair
Correct.
enough. That applies to everything in life, basically.
Yes.
But then, do you still tread carefully? Because I mean, if you get a tattoo at 18, I mean, you can get those removed, right?
Yes. Correct. Yep.
But I mean, there's the elements to plastic surgery, I mean, if not all, is irreversible, right? And you, I mean, if I did everything I wanted to do when I was 18, like,
Yep.
I would have, yeah, it would have been a terrible scenario for me now in my 30s. But
Okay,
I
so
still tread
there's
carefully.
another element to that, though, isn't it? That who you are at 18 is very different when you're at 28. So we know that 18-year-olds are not necessarily, once upon a, I left home at 17. I was running a household with a partner at 17. I would start med school at 17, but now the current generation, it's not a criticism, they're adolescents to 28. And so the question is whether or not you are making a safe decision at 18 versus a decision at 28. But this is all about respect. Anyone is entitled to have the conversation, and then you've got to put it into context. So if the reasons for them choosing to having something done are valid and real, then, and you are, as the surgeon, happy to proceed and capable of giving the patient what they want, then there is no issue with that proceeding. It's a two-way street.
No, fair enough. All right, let's switch gears a bit now,
Yep.
and let's go to like what you're actually doing day to day, right? Because it's in the name, surgeon,
Yep.
surgery. But how much of your week, your month, again, if you were to split it out in percentage wise, are you in the office doing consultations, doing admin work,
Yep.
compared to actually being on the operating? Because operating theatre, again, not to be crude, that's how you make your money, right?
Yeah.
Without
Well, it's not the sole way we make our money. I'm a surgeon. We love operating. We love being in the. If I had my time, I'd be in the operating theatre 100% of the time, and all the other aspects of running the practice would not be managed by me. But that's not practical. So 50% of my time is in an operating theatre, and 50% of the time is running the other aspects of the business or practice. So that's admin, staff related issues, but also remember, to operate on someone, you've got to see them. So you've got to consult. You're not just operating on them, you're also following them up in post-operative care. So I have a very strict protocol. I'm seeing people a week, 3 weeks, 6 weeks, etc. And so that's time consuming, but you can get through quite large numbers quickly with efficiency. But basically 50% of the time is the operating theatre, 50% of the time is the business and practice otherwise.
Right. Okay. And then I mean, you run your own practice, right? Is
Yeah.
that how most of the plastic surgeons do it? Are these big
So
groups or?
don't get me. So it's a little bit like the Wizard of Oz. There are a whole bunch of other people behind the scenes that are helping me run my business. So I'm one aspect of the business. Yes, I'm the boss, but I have a practice manager. I have reception staff. I have contractors. I have a full-time bookkeeper. I have a nurse. So one surgeon is, for the most part, in a practice of my size, probably got 5 other staff on board. I can't run my practice without a practice manager, because I'm not here all the time. I'm not necessarily contactable while I'm operating on a patient. I'm not picking up my phone, and so I need other people to run those aspects. But yeah, in terms of well, am I the only surgeon in the practice? Well, that's the norm. To be honest, it's unusual to run multi-surgeon practices in plastic surgery or cosmetic surgery in this country. They tend to not work well.
So why do you say they don't work well? Is it just a money thing, or?
So listen, so it's not all about the money. But you think about it. If I take on so I've done it many times before. I've taken on associates, but I have a little rule. So what I do is I take on a junior surgeon who's just qualified, wants to get a sort of a leg up and be introduced to how a practice runs. So what you do is you contract them and say, okay, you're going to work with me for a year or 2 years, and then you're going to seek into your own private practice. And what it does is it gives them a chance to see how private practice works without the costs associated with running a practice. And what an associate role means is that I take a percentage of their income. So, I'm not making vast profits off them, but I'm certainly not running at a loss, but I'm giving them the opportunity to go right into a private practice and see how it works. But do I want to work with another surgeon at this stage in my career? No, because why would another surgeon want to spend all their time with me when they can do exactly what I do and keep 100% of their income? Does that make sense? And it's not just about the money. Surgeons are, there's a little bit of ego involved. A lot of surgeons believe that only they are the best at something, which can be true in some elements, but not always. And also, we like to run our own show. So we like being the boss. And it's hard if you're having to compromise with another person who's of equal talent or, equal age. It tends not to work. There are a number of cases in the city, in Sydney at least, where 3 or 4 surgeons have had major falling outs and the business has gone kaput. So most plastic surgeons, certainly in Sydney, work in single primary surgeon practices, but they'll take on a junior for a short period of time to give them a help up.
Right. So it's not like, and I don't know if this is an appropriate parallel to draw, but lawyers, right? Like you see,
Yep.
whatever, Harvey Specter Lit, or whatever the name of the firm is in Suits, right?
Yep.
How there's three
Never seen it.
Never seen Studio. No, you're not missing out on much. But there's 3 partners, and there's a bunch of lawyers that all try and make partner at the firm.
Yes.
It doesn't work like that. Like there's no big organization where there's a bunch of plastic surgeons.
So there's a particular reason for that. You cannot practice in this country under someone else's provider number. So every single person, every medical practitioner who wants to work on patients in the public arena has to have a provider number, and so you have to bill under your own provider number. So it makes no sense to be working for someone else under that. You can't do it under their provider number, but it makes no sense, because if you can go out on your own under your own provider number, you keep 100% of your income.
Right,
in a nutshell.
Okay. No, fair enough. All right. Well, then, okay. Now on income, and I want to approach this question delicately, right? So if I'm, you've mentioned it snowballs, right? So the longer you get into this industry, the more referrals you're going to get, the more money you're going to make. So I assume it's sort of a steady incline. When you first start out, you're not going to be making much, but when you're on this side of your career, when you're first starting out compared to when you're sort of ending out, like what round ballpark figures is a person expected to make?
Okay, well, the first thing is you're never going to be broke as a plastic surgeon, reconstructive surgeon, or aesthetic surgeon. I can assure you of that. In this country, it's a growth market. It's an aging population. People are staying in the workplace longer. They want to look better for longer. So the cosmetic surgical industry and the non-surgical industry is certainly a growth market. It is only getting bigger and bigger. It's billions of dollars spent in this country every year. In terms of personal income, you're going to, if you're in my side of the field, you're going to earn millions of dollars. You will be earning millions. I will temper that a little bit by saying that the cost of running a high-end, reputable practice is not cheap. Staff costs are expensive. Insurances are expensive. To insure yourself, public liability, medical defense, work cover, those are expensive. Insurances are very expensive in this country. One of the reasons why the medical defense fees are so high is because we have a high litigation rate, and those fees are then offset around everyone. So that's an expensive part of the practice. So, and you'll get those fees, in all honesty, are being charged in one way or another to your patients. But yes, you're never going to be broke. Having said that, there's if you chose to stay only within the public system, which is a rarity amongst plastic surgeons, you would be earning a VMO rate. I haven't been a VMO for 3 years now, so I left the public system 3 years ago. But when I left, I think the hourly rate was, and I'm sure listeners would be glad to hear it. It was about $250 an hour. Now, I'm not going to tell you what I can charge as an hourly rate currently, but we would argue whether the Linda Evangelistas of plastic surgery, I'm not getting out of bed for $250 an hour. Does that make sense?
It does.
And you can interpret that any way you want, but the bottom line is it's a lucrative industry. Of course, your reputation is everything. So, but there are also laws in Australia. You can't just charge whatever you want whenever you want. It has to be fair and equitable. So there are some guidelines, but also it's a competitive market. So if you outprice yourself compared to your colleagues, no one's going to come to see you. The other thing is patients are very savvy. They're well informed well before they ever get to actually see me face to face here in the practice. They've usually contacted me already on something like HubSpot. As it happens, I allow people to contact me directly on my private mobile. And so there's an ongoing conversation well before they've made it into the practice. And cost is a big part of that. They will already be aware of costs, for instance. And they also know I might be one of 3 people that they've contacted. So they've got a fair idea of what they're likely to be charged out in the community. And so you're competing within that market. And so you've got to price point properly. There's one thing I will say to people, though, is never undervalue your skill. Give nothing away for nothing. Even advice can be monetized, basically. That's the purpose of a consultation. There's no such thing as a free consultation, not certainly in my industry. And I think if I'm spending an hour with someone across the table, I'm devoting that hour purely to them and allowing them to ask me anything they want. The patient's expected to pay for that. There's rebates for it and stuff. They get money back from Medicare, etc. But never undervalue your skill set. Charge an appropriate rate is the bottom line. That goes for anything in life, to be honest.
Because do you think what younger plastic surgeons are undervaluing themselves? Is that why it's
no? I would argue the complete opposite. I think that the younger plastic surgeons coming through, and this is where I'm going to show my age a little bit. They want what I have now. They don't want to get to my stage by waiting 20 years. They want it tomorrow, and there's nothing wrong with that. But that's because they see the work-life balance differently from when I started out. The surgeons training me expected me there to be in the system all hours, no holidays, never see my wife, never see my children. I'm sort of turning on the waterworks a touch, but now people want a better work-life balance. So they want better money earlier, and they don't expect to be working 20 hours a day to get it. And I don't have a problem with that. I think you only live one life. You might as well live it well. But yeah. To come back to the question, it's a lucrative industry.
Okay. So you can definitely make a lot, but you did mention cost, right? So
yes.
Insurance was. So I assume wages would be number one. Insurances maybe number
so
two.
Actually, in this state, insurances are number one, followed by staff salaries. Yeah.
Followed by staff salaries. Then is there any other big ones, or those are the big? Like, do you have to pay? And maybe I don't know how this works, but do you have to pay the hospitals to operate there? Like, do they get a fee, or they do that?
No, so we don't pay. So that would be considered inducement. So no, hospitals charge either the patient's health fund if they're privately insured and they're willing to accept that, or they've charged the patient directly. Now, all of the cosmetic surgery I do, that's not covered obviously by health funds or Medicare rebatable, and so therefore the hospital is charging that patient. We estimate for them, so they give us lists of what they expect the patient to be charged, and we quote for the patient in the practice, but they don't actually pay anything to us. They pay that to the hospital directly. I do not have to pay a hospital to be allowed to work in their facility, but what I am expected to do is to bring patients to their facility so that they make money off those patients, basically. Believe me, hospitals are not there for the benefit of the patient. They're there for the benefit of their shareholders in many circumstances, and whoever else has got a cut of that facility. And that sounds very, it sounds quite cynical, but the surgeon should always be there for the patient. The money is secondary, and I personally do not actually get involved, if I can help it, in the discussion around patient finances or costs. That's why I have staff. So my practice manager, she knows I will write on a little sheet what I expect the fee to be, but she'll actually have the formal discussion about the cost breakdown, for instance. But hospitals, we do not have to pay hospitals to be able to work in their facility. They it's a privilege for them to have us in their facility. I would argue they can't run a hospital without surgeons. Put it that way.
So are they? What's the power dynamic here? Are they going out hunting for surgeons, being like, "Hey, come operate at our hospital," or is it the other way around, where there's surgeons that come along and they're like, "You know what? You don't give us enough business." Again, as cynical as that sounds, and
No,
they boot them out.
it's actually not cynical at all. It's actually quite correct. So there are certain specialties that attract better rebates from private health funds, and also from what, like the implant. I can't remember the exact terminology for it, but there's, patients that are having orthopedic implants in attract a lot more funding to the hospital from the health fund than me as a plastic surgeon. So in fact, there's an issue at the moment for plastic surgeons in this country, and that it's many private hospitals will now not agree to have plastic surgeons in their facilities because they don't feel that they make enough money for the hospital. They're making enough money for themselves, of course, but not for the hospital. And hospitals are private institutions. They can do whatever they want. They're businesses. They can choose to have the mix of surgeries that they want. But plastic surgery covers a number of different arenas. So I can be in a theatre and an orthopedic surgeon can come into my theatre and say, listen, I've got an issue with a wound here. I can't close the wound. Can you come and give me some advice and help me? That we don't want that opportunity to be lost. But certainly plastic surgeons are not seen as being particularly lucrative by private hospitals. Cosmetic surgery, so not being done through a health fund or with a Medicare rebate, basically hospitals can charge whatever they like to that patient, but they too are competing for the patient. And so they've got to be reasonably fair, and they've got to, set their fees appropriately so that patients aren't put off going to their facility.
So if you're a plastic surgeon and you can't get a hospital on board, isn't that like that's an Achilles heel, right? Like there's such an upside to this, right? But if you can't find a hospital to operate on, doesn't that screw you?
It doesn't quite work that way, because the reality is that there is what's called ad hoc availability. So for instance, one of the hospitals I go to has now 9 operating theatres, and not all of those 9 operating theatres are completely got surgeries going in them 5 or 6 working days of the week. And so that means there may be an empty operating theatre. And what they'll do is they'll offer that ad hoc list or by email to any surgeon out there who's accredited. You have to be accredited to go to a facility, so you have to get approved to operate there, obviously. And then and they'll say, well, listen, that Friday afternoon is available. Would you like to operate here? And that's often how young surgeons get going, is they don't have regular fixed lists because they don't necessarily have enough work to fill a list. But hospitals have got to work on the other side of the equation. They can't have staff sitting there for 10 hours and me only utilising it for 1 hour. That's not cost effective for them. Does that make sense? And if you underutilise your list, that list will be taken off you. And that's the risk that plastic surgeons and cosmetic surgeons have, is if there's a downturn in the industry, then you may not be able to fill a list. But filling lists is also due to, at my stage in career, I have no trouble filling lists. I'm busy. But, if I became irrelevant, then I may find I'm unable to fill a list. I think
so then... No, go on.
I think it's harder for young surgeons to get going at this point. It's hard. Running a business has become harder and harder, and it is a business. Running a practice is difficult. There's a lot of cogs to it, a lot of components. And one of the things that certainly in my day you weren't taught was how to run a business. Basically, there were courses you could do, but basically you did it as you went. Now, many of the younger surgeons, there's actually preparation for practice type courses regularly. It's actually part of the curriculum, and and so they're a little bit better prepared. The social media aspect, remember that when I started out, there was no such thing as social media. Now, if you're not got a presence on social media in some form or another, you're really doing your business a disservice. And you're probably doing your patients a disservice, because many patients will approach you through those platforms.
Right. So, if you're, because you said if you're accredited, you can get in these ad hoc spots, right?
Yes.
If you're, is there a way that you can get iced out from the industry if people don't like you, or is if you're accredited, you have equal opportunity like everyone else? They can't just say no to you because they're like, oh, we don't like that
Well,
guy. We don't want.
it's like working in any other environment. If you're an asshole to the people that you're
Mm,
working with, the nursing staff, the administrative staff, the people that own the hospital, then they can ask you to leave the facility. They can say, "Well, listen, we don't want you working here." So you have to create a nice working environment for not only yourself but the people around you. They wouldn't ice you out as such. They would just say, "Listen, I don't think you're filling the list. I think we'll put you onto ad hoc if they didn't feel you were running the list." You can't. You have to be careful about discrimination. You can't say I don't like you, and
mm,
therefore I don't want you working the facility. That sets you up for a discrimination suit by the surgeon against the facility. But the bottom line is when you've worked in an environment where you've not liked someone, you can ignore them, and the ignored person will feel that okay, well I'm not wanted here, and they might go of their own volition. But you have to be very careful in the workplace. It's very different from when I started out. Bullying, discrimination, harassment is very broad terminology, and yeah, you've got to play nice. You play
no.
nice in the environment you're working in, they'll play nice with you too. I can assure you.
Okay. So then, all of the like obviously hospitals is one stakeholder in this transaction. I assume that there's anesthetist, and I never pronounced that right.
Anaesthetist.
Yeah. So do you? I mean, do you choose who you work with? Are you sort of given who the hospital gives you? Like, how does that relationship work? Is it again
Okay,
like?
so it works very differently in the public versus the private system. So in the public system, for the most part, it's whoever's rostered on. And there's predictability, like the same anaesthetist might do the same list once a month. And if you're only doing that once a month, then you'll have the same anaesthetist. But you don't actually have a choice. Neither, in fact, does the public patient, I might add, for the most part. They'll often have met this surgeon or the anaesthetist just as they're coming into the operating theatre. In the private arena, it's a different system. So I choose who I want to work with. And so, the two anaesthetists that I've worked with for, now 15, 16 years, they weren't actually close friends of mine, but I had experiences with them. And I thought that they would work well with the type of clients that I operate on, and more importantly, would work well with me and the rest of the staff. And sometimes that can be a bit trial and error, but and if you don't get on, you have to mutually agree to not work together. But that ultimately, the anaesthetist would disagree, but the surgeon runs the theatre. And so we are really setting the staffing. Where it breaks down a little bit is is nursing staff. That's not always consistent. Surgeons of my age, and I've been in the system long enough, basically the same nurses will want to work with me all of the time. So that's come through just experience, and and you work out pretty quickly who you enjoy working with and who you don't. And that works in both ways. Nurses can choose not to be in a theatre with a surgeon. They're not obliged to. They can say, listen, I would rather be allocated to another surgeon, and that's fair enough. They're entitled to do that.
Fair enough. All right. I'll this will be the last topic that we'll touch on. I think we've pretty much covered everything that I've got on. Towards the end of your career, right? Because I know guys who are working desk jobs that are, working into their 70s, 80s, right? Like as long as your mind's still operating, right? You can still keep working, but surgery, not just plastic surgery, but any surgery, I assume, is a bit different, right? You need to have steady hands. Is there a shorter time period to this, or
Okay, so that's a difficult question because there are plenty of surgeons that are more than capable of working well. There's actually no law that says you have to stop as a surgeon at 65. That's the first thing. And it comes down to skill set. You've mentioned the steady hand, so that's a little bit of a myth. So you do not have to have steady hands to be a surgeon of any kind. What you have to be able to be able to control the hand. And there are various ways that you can position yourself, spin yourself, control yourself to actually have the steady hand. As one ages, the hand-eye coordination can change. And I think once you lose hand-eye coordination, that can be an issue with particularly fine work. And a lot of the plastic surgery type of stuff is very fine. A lot of the cosmetic stuff is quite fine. But there is no particular reason why, if you're not still skilled and you've kept up your continuous professional development, which is a legal requirement, why you can't keep working well into your 70s. Whether or not you want to after years and years and years of running a business is very different, but there's no law that says that you cannot. Even in the public system, there is no law that says that surgeons must retire at 65 or 70. But again, there's a it's like leaders of it's like, I use it as an example. Think of what's his name, Joyce at Qantas. He was a leader that started out well but stayed on too long. Basically, he didn't know when to leave. Good surgeons know when to, I think, lay down the tools. So if your complication rate starts going up, your patient complaint rate is unacceptable or going up, then I think you need to address whether or not you're capable of continuing in that practice, is the bottom line. Yeah. All the other thing is there are young people coming through. They deserve a chance to have a slice of the pie, if you like. And, and at some point you might say, well, listen, I'm going to take on a young person, and that younger person is going to do certain aspects of my practice. So I could say next week, decide I'm no longer going to do breast reductions. I'm going to get a surgeon in, and he or she is only going to do breast reductions in my practice. And that would be a way of me so gently easing myself out of my own practice and also giving someone else a bit of a chance. Does that make sense?
It does. It does. Do you? And it may be just because of personal decisions to say, you know what, I've made enough money and I want to retire early and enjoy the golden years. But do you think the average age of the average retirement age of a plastic surgeon is a little bit lower than that of an average career, or do you think it's pretty much?
No, I think it's a little older. I think that plenty of plastic surgeons are still operating at 70. And it's not about money, because if you haven't made enough money to retire on by the time you're 70, you've done something wrong with your career. Is the bottom line. That's being very honest. And so it comes about. Surgeons are notorious, perhaps, and this is across all surgical specialties, for not having things outside surgery. Perhaps you've got to have other interests. You've got to have a life outside the practice, and you need to start setting that up, in my opinion, early. So you've got to have interests from your early 50s on. Most of us have a plan. Of course I'd like to retire tomorrow, but would I be able to fill my day with other things? Probably not. Would my wife want me at home? Very definitely not. And so and more importantly, I want to keep working. I enjoy the work. So if at some point you don't enjoy the work, give it away, because if you don't enjoy it, you won't be any good at it anymore, to be honest.
Oh, fair enough. I think that's a good way to end it. I mean, is there anything else that you think that I should have asked about your career that's worthwhile discussing?
I think there was a little bit of focus on the financial side of it. But I'm going to say one thing to end is the money is not the be all and end all. You got one thing you can be fairly certain of as a surgeon: you're not going to be doing anything else for the rest of your life. Once you've made that decision and you've trained and you've spent all those years training, the chances of you pivoting to another career are highly unlikely. Now, my children, early 20s, I'm told that they can expect to have 4 careers over their lifetime. That to me would be just shocking. I could never have imagined that. So you're going to be doing it for a long time. You've absolutely got to enjoy what you're doing. It doesn't matter whether it's plastics or some other specialty. You have to enjoy getting out of bed and doing that every day. And that's about job satisfaction, and that is what you get out of the patient and also what you get out of the people around you. And yeah.
And I assume you love it, right?
I do love it. But it's like anything. You'd have days where you think, oh, Jesus, I really don't want to face this today. And I think, in all honesty, when you have a complicated patient or a complication, that can knock you for 6. You can question and second guess yourself. Does it make you want to stop doing the work? No. It's probably good for you because it brings you back to ground, and makes you reevaluate what you're doing on a day-to-day basis, including how you manage a patient. But but there are days, certainly, I put it this way, I enjoy my breaks, and you need breaks, and you definitely need a good work-life balance. And that's the thing that you'll learn as anyone as a doctor, as they pass through, they'll actually get better at the work-life balance. They'll realize that you only lead one life. The work's good stuff. Okay, so it's a privilege to be a doctor in this country. Remember that. It's a privilege to be in any specialty. You're going to have a good life, but it's one life.
Perfect. All right, we'll wrap it up there. Thank you very much, Ben, Dr. Norris, for doing this.
No, really great questions. I've really enjoyed it. I hope it's useful. Do with it as you. Okay,
all right. Thanks, man.
Take care.